This just in, your patient's Foley is dirty with bacteria and no one is surprised. I mean, we aren't exactly putting this plastic hose in the cleanest of environments, and even if it starts out clean, it will eventually get dirty, because we're essentially creating a highway through poop for bacteria to ascend. And ascend they do, with about a 7% risk of bladder colonization per day of Foley catheter use, leading to 50% of patients colonized at 1 week and 100% colonized with chronic use. This is likely due to biofilm formation, which is when bacteria secrete snot to protect themselves from environmental stressors and antibiotics. The majority of catheters have biofilm on them by the time that they're removed. Well, what happens to these patients colonized with biofilm-producing bacteria? In one study of 235 patients with bacteriuria, the vast majority were asymptomatic, and there was no difference in the prevalence of UTI symptoms between those who were and those who were not colonized. Additionally, colonization only extremely rarely led to bacteremia. So overall, bacteria in the bladder of catheterized patients is largely inconsequential. On the other side of things, overdiagnosis may cause anchoring bias, thinking you're on the right track when you actually aren't. The urine cultures are ordered in response to a fever in a cath patient. Clinicians are tempted to associate the positive culture with the infectious syndrome, even though it is rarely the cause. More commonly, other infections or non-infectious causes are eventually decided to be the cause of the fever. A third of these cultures are never treated because something else pops up, and out of the remainder, results from the urine culture rarely results in changes to the empiric regimen of antibiotics. So your urine culture may lead you away from the actual diagnosis and likely won't change your management. Despite this, we are trained to reflexively send blood culture, urine culture, chest x-ray in any patient who gets sick in the hospital, even if they have a Foley. But this practice isn't even supported by the guidelines that suggest only checking urine in very specific subsets of patients because bacteriuria is rarely symptomatic, the cause of fever, or leads to bloodstream infection. So fight against your baseline inclination to send urine on catheterized patients. In these patients, colonization rates are high, but are likely inconsequential. Our labs, cultures, history, and physical can't distinguish colonization from true invasive infection. And sending the culture that documents this colonization may still result in a reportable CAUTI to the NHSN. And you're being forced to make decisions on bad information. Treating asymptomatic bacteriuria in cath patients is unlikely to benefit patients. And you'll have to contend with the possibility of missing the true infection and selection of multi-drug resistant bacteria through the overuse of antibiotics. And if you decide not to treat, which is the right answer, you should feel comfortable that there are minimal consequences to this strategy. That said, there are, of course, exceptions to every rule, and some patients do deserve urinary workup as a cause of fever or destabilization in the hospital. But using clinical suspicion as opposed to reflexive testing is key in the approach here. Summing up, UA, urine culture, and H&P are unreliable as indicators of infection in catheterized patients. Consequences of missed CAUTI diagnosis are really minimal, especially with pending blood cultures. Consequences of overdiagnosis and treatment are likely greater. Only check urine if nothing else makes sense and add it to your third tier of diagnostic evaluation for sick patients. Thanks for listening. Email me with questions and follow me on Twitter.